The meeting will come to order. Good afternoon, everyone. 1, 2. We do not have a quorum. So that's 3. Welcome to today's Subcommittee 1 meeting for Labor and Commerce, Insurance and Financial Institutions. We have a pretty full docket today, so we're going to get started right away. We're going to go a little bit out of order just because some folks have some pressing business to get to, and then we'll take care. I'll let them. I'm going to do some administrative things first, get the folks who have time-sensitive issues, and then we'll go back to the regular order. First, I just want to recognize a couple of bills. Delegate Waxman, by his request, we are striking HB 1956 and voice vote. Is that a voice vote? Do we have to vote or anything like that?
It's recorded.
Yes. So
need a motion.
So I need a motion and a second. It's been moved and properly seconded. If we could open the rolls and place your votes on the table to strike HB 1956. Okay. That motion is approved 6-0. Thank you very much. All right, next we're going to, also by request of the patrons, HB 1942 and HB 2100 are going to go by for the day. Need a motion? In a second? Properly moved and seconded, and recorded vote.
It's a voice.
Oh, if both.
It's
Pass
by
by?
for the day.
Oh, pass by though. Okay.
That's
Got it.
see here you go.
Yes. Okay. Voice vote. All in favor? All opposed? Okay. Those two bills are passed by for the day. Let's see. Next we have. Hold on 1 second. Okay. So the next one we're gonna lay on the table. We've spoken with Delegate Martinez, HB 1765 from last week. We will need to record this. So
I don't even have it on the agenda this week. Yeah,
it is. It's the first one, HB 1765.
sorry, 17.
Yes. Moved and properly seconded. Thank you. We go ahead and table it. It's a recorded vote.
Yes, ma'am.
Go ahead and open the rolls. We can take the vote.
As soon as it hits the board.
And we will get to the next one once we get to Delegate Simon's bill. Go ahead and, this is tabled by a vote of 6-0. Go ahead and close the roll. Thank you very much. All right, so let's move to the agenda. First up, we're going to have Chair Ward present on her bill, HB 1923.
Thank you, Madam Chair and members of the committee. First, I'd like to move the substitute.
Been properly moved and seconded?
Thank you.
You have the floor.
Thank you. Madam Chair and members of the committee, House Bill 1923 is a critical legislation. It ensures all licensed midwives in Virginia, whether you're a licensed certified midwife, you're a licensed midwives, or licensed nurse midwives, that they would all receive 100% insurance reimbursement for covered health services, ensuring parity and procedural code reimbursement. Currently, only CMNs are eligible to fully be reimbursed, while LCMs and LMs I can break it all down for you, but they receive partial or no reimbursement. This disparity limits access to care, especially in underserved rural areas, and it discourages midwives from practicing in communities that need them. We want to expand access to maternity care, particularly for vulnerable populations and women of color. We want to promote cost savings through lower intervention rates and optimize resource allocation in birth settings. Will ensure equity, acknowledge their cost-effective, safe care, and incentivize the use of midwives. Its equal reimbursement allows all midwives in underserved area, addressing the physician shortages and reducing maternal health care disparities in rural and low-income areas. Midwifery care reduces costly interventions such as cesarean sections or deliveries and lowers complications, saving Medicaid money over time while improving maternal and infant outcomes. I have some individuals with me that will help testify to this bill, so you're just not hearing from me, but from the real professionals. This bill is a recommendation of the Rural Health Select Committee and part of the omnibus package. Virginia has an opportunity to lead in equitable maternity care and less critical gaps in maternal health. So I ask that you please support House Bill 1923 to ensure all families, regardless of locations or income, can access high-quality midwifery care. Thank you, Madam Chair.
Thank you, Chair Ward. Are there any questions from members of the committee? Okay, seeing none. Are there any speakers in support of the bill today? If you are, would please come forward. Thank you.
Good afternoon, Madam Chair and committee. My name is Miranda Schindler. I am a licensed midwife.
Sorry,
Yeah.
one thing just to qualify. So please keep comments to 60 seconds, max of 60 seconds as we move forward so we can make sure we get through everyone. Thank you.
Yes. I'm a licensed midwife here in the Commonwealth. I am speaking today on behalf of the Virginia Midwives Alliance, asking for your support of House Bill 1923. House Bill 1923 will expand access to maternity care and reduce maternal health disparities, aligning with recommendations from both the Rural Health Select Committee and the Omnibus package. House Bill 1923 will also improve access for families to provider type of their choice and place of birth that aligns with what they believe will best serve the needs of their individual family. We thank Delegate Ward for sponsoring this bill, as well as Delegates Jones and Martinez for co-sponsoring, and we ask your support of HB 1923. Thank you.
Thank you. Go ahead. And for those who are speaking on the bill, if you want to come forward a little bit closer. Thank you.
Madam Chair and members of the committee, my name is Jessica Jordan. I'm a retired certified nurse midwife. I served the women of Virginia for 25 years before I retired. LCMs and LMs, while having a different scope of clinical skills from physicians, have shared overlapping skills, and how they are coded and submitted is identical. Medicaid already reimburses CNMs at 100% of the physician fee schedule, acknowledging the cost effectiveness and safety of midwifery care. Extending this parity ensures all qualified midwives are treated equitably and incentivizes the use of midwives, which improves outcomes and reduces cost. Reimbursing LCMs and LMs makes it financially viable for them to serve in underserved areas where physician shortages are common. CMs and CPMs are more likely to work in rural and low-income communities, improving access to prenatal and delivery care. Equal reimbursement strengthens the midwifery workforce and addresses maternal health care disparities.
Thank you very much. Welcome.
Good afternoon, Chair Maldonado, Delegate Ward. Thank you for bringing this important bill. I am Catherine Haynes, speaking on behalf of the Virginia Interfaith Center for Public Policy. This bill is connected to our work in improving maternal health equity. In a past life, I was a Virginia licensed certified professional midwife. As a mom of 4, I was unable to afford to practice given the reimbursement rates. One of many, many examples, the state law understandably requires a newborn screening, which is a heel stick procedure. The cost is $138, and Medicaid for CPM would reimburse $103. So there's so many examples, and you can't improve maternal health through access to midwives if you don't have any midwives. So I would urge you, for all the moms out there like me who needed a midwife, please pass this bill and increase that access.
Thank you.
Good afternoon, Victoria Richardson. I work with the Virginia Poverty Law Center with the Center for Healthy Communities. I want to thank Delegate Ward for bringing this bill, and we support this bill, support expanding access to care for all women in Virginia. Thank you.
Thank you. Okay. Anyone would like to speak in opposition to the bill?
Madam Chair, Doug Gray, on behalf of the Virginia Association of Health Plans. I'm not speaking in opposition to the bill, but I am trying to give you some background and information on what this legislation does. It adds 2 mandated providers to the list of the existing mandated providers. One is the licensed certified midwife. The other is the licensed midwife. Some health plans pay both of these, some do not. So it isn't a routine thing at this point in time for all health plans to pay these providers because they're not mandated providers. So what this bill seeks to do is to make them mandated providers, and we are not opposed to the concept of doing that, but they're going to need to be credentialed, which is a requirement of all providers in a health plan. The second section about paying the same as a physician or nurse, well, I guess I'd have to use the right term. I guess it would be a certified nurse midwife, is a little more challenging. In Medicaid, they might do so. In Medicare, they might do so. But the rates in Medicaid and Medicare are quite low. The commercial market is quite different. So that is not a simple and easy topic to do. And frankly, I'm not sure it's something we've done before. And if we go down this road, I think we're going to have many of the other providers, there's 18 different providers in Section A, wanting to get paid the same as a physician. And I think that's a challenging thing to work out. Just so you know, there are lots of physicians, and we pay them differently. And they all have different levels of expertise, settings, specialties, et cetera. Thank you.
Mr. Gray. Thank you. Hi.
Hi, Madam Chair. Clark Barano on behalf of the Medical Society of Virginia. To Doug's point, physicians are paid differently. It depends on the contract, depends on where they work, depends on their expertise. So when it says paid the same as a physician, that's hard to define. Again, we don't have an issue with the bill. We are not in opposition to it. However, we do have concerns, to Doug's point, of this being to use the lobbying phrase, camel's nose under the tent. If we give this away, each identified healthcare profession may approach you all over the years and say, I want to be paid this rate, I want to be paid this rate. We need to be very careful if that is the route we're about to go down as a General Assembly. Thank you.
Thank you. Is there anyone else that would like to speak on behalf of the bill? Do we have anyone online that has shown up? Nope. No. Okay, thank you. All right, Chair Ward, would you like to have the last word?
First of all, the purpose of this bill is because we know the problems that we've been having with maternal health care. That's the reason for this. If we did not need midwives, we would not even be having this discussion. But many people have forgotten that once before, that's all you had with midwives. There were people, particularly my people, couldn't go into a hospital, and many of them were just born with a midwife. So I want us to remember that this isn't anything new. This has been going on for years and years and years. And all the midwives now want to make sure is they are paid equitably, because they are all midwives, but different classifications, and depending on where you work or what you do, you're paid at different rates. And this is all this bill is asking for, is equity.
Thank you, Chair Ward. Now, I do believe, did you have a question? Yes, okay, please, Delegate Wilt.
Speaking of the bill, Madam Chair, at the appropriate time.
Okay, please go ahead.
Thank you, Madam Chair. So just to be clear, Delegate, I don't know if you noticed or not, but I had signed on to your bill originally, and because I've met with folks that represent this industry back home, and so I agree with you in concept. But when I signed on, when I agreed, I was under the impression that it would apply to Medicaid patients, and I don't believe that this does. But then also the notion of drawing all these other people in. And so that brings me concern. I am with you in concept. I think our midwives deserve doing the exact same thing. There should be equity there, but the way it's drawn, I have concerns. So I'll not be supporting the measure. Thank you, Madam Chair.
Thank you, Delegate Wilt. All right, I believe this has a letter to refer to appropriations, and just want to say that this committee works by
Madam
motion.
Chair, move to report and refer to appropriations.
It has been moved to refer to appropriations and properly seconded. We could open up the rolls. Members could cast their votes on the board. Okay, this bill will report and refer to appropriations by a vote of 5-2. Thank you very much, Chair Ward.
Thank you so much, Madam Chair, members of the committee.
Next, if we could have Delegate Simons come. Yes. All right, I think before we begin, we have a little bit of administrative work to do with your bill and Delegate Keys-Gamarra's HB 2033. And it is my understanding that Delegate Keys-Gamarra and you have come to an agreement, and she'll be rolling her bill into yours into 1828. Is that correct?
Yes.
All right. Can we get a? I'm sorry, did I get that wrong?
No, I'm just asking.
Yes, that's correct.
All right.
Yes, thank you, sir.
Into
1828.
You need a motion?
Yes,
Yeah, it's verbal, but yes.
Yes.
I move that we incorporate House Bill 2133 into Delegate Simon's House Bill 1828.
Correct.
Do we have a second? Second, it's been properly moved and seconded. Okay. All in favor?
Aye.
All opposed? All right.
Thank you. Thank you, Madam Chair. We have lots of people excited about this bill, so I did make Delegate Keys-Gamarra a chief co-patron, and Senator Tara Durant will be carrying this bill in the Senate. Members of the committee, Chair Maldonado, this bill seeks to reduce barriers in the treatment of breast cancer. Breast cancer impacts all of our lives. Each of us have a loved one who has been impacted by it. A few years ago, I got the call that you never want to get from my mother, who told me in a shaky voice that a regular mammogram screening showed that she had a lump and she needed to follow up with diagnostic imaging. She is among the approximately 8,000 women who are diagnosed each year with breast cancer in Virginia, but luckily for my mother, her breast cancer did not spread. HB 1828 would eliminate out-of-pocket costs for these medically necessary diagnostic and supplemental breast images, such as MRIs, ultrasounds, and diagnostic mammograms. These out-of-pocket costs for these screenings can be anywhere from $350 to $1,000 out of pocket. This bill is a bill that would save lives, because when women can't afford to pay out of pocket for diagnostic imaging, they can put it off, their cancer can advance and become more deadly and costlier to treat down the road. If this bill seems familiar to members of the committee, it's because I have been working on it and carrying it for the past 2 sessions. And I am happy to report that it has been sent to the HERC and has finally passed through the HERC process. The legislation has passed in 25 other states, so let's make Virginia the next success story in the fight against breast cancer.
Thank you, Delegate Simons. Are there any questions from members of the committee? Okay. First, we'll take comments from the room. Those in support of the bill, we will hear first, followed by those in opposition, and then we will go online. And please keep your comments to 1 minute or less. If you want to come up and come a little bit closer so we can hear your wonderful voices. Welcome.
Good
Please remember to
afternoon.
just remember to state your name and affiliation. Please welcome. Please proceed.
Good afternoon, Chair Maldonado. My name is DeAndrea Newsome, and I am representing Susan G. Komen. And we are urging each of the members of this committee to support HB 1828, which relates to coverage for medically necessary breast imaging. We advocate on behalf of the estimated 8,250 people that Madam Delegate Simons mentioned in Virginia who will be diagnosed with breast cancer, and the estimated 1,100 who will die from the disease in 2025 alone. Mammography is the only initial step in early detection, and it is not able to diagnose cancer alone. Early detection of breast cancer is not possible without medically necessary diagnostic follow-up and additional supplemental imaging required to rule out breast cancer or confirm the need for a biopsy. We urge you to support this bill, and we thank you so much for your time.
Thank you.
Hello, members of the committee. My name is Kirsta Millar, and I represent the Virginia Breast Cancer Foundation. We also support this bill. We hear daily, we get calls to our office all the time, people asking for our help with paying for their follow-up diagnostic mammography or ultrasounds. We just got a call at the end of December, a woman who had a $900 bill. Her doctor recommended that she has a follow-up, and she couldn't pay the bill. She wanted to know if we could help her. We hear this all the time. We know, as everyone has said, that you can't diagnose breast cancer from one mammogram. It's essential for the process. When you get diagnosed earlier, your outcomes are better, it costs less to treat, and it reduces the chance of the cancer spreading. We know this bill will save lives. It will also save money to the healthcare system. Someone diagnosed at stage 1 versus stage 3 or 4, it could be a savings of $50,000 a year to the healthcare system. So for all those reasons, we support this bill and urge you to pass it. Thank you.
Thank you.
Madam Chair, members of the committee, Kelly Fitzgerald representing the American Cancer Society Cancer Action Network. ACSCAN just actually last week came out with a new report called Out-of-Pocket Costs for Follow-Up Tests After Abnormal Screening Mammograms and Their Impact on Cancer Survival in Breast Cancer. And I think this statistic really says it all. Out of this analysis found that out-of-pocket cost sharing is estimated to result in 1.1 million women delaying necessary breast cancer diagnostic testing and imaging in 2024 due to affordability issues. Just as alarming, out-of-pocket costs appear to have an impact on future screening. Approximately 378,000 more women are likely to skip future mammograms in 2025 due to a fear of subsequent out-of-pocket cost. It's an important bill. We support it. Thank you for your time, and thank you, Delegate Simons, for going through the HERC and years of working on this.
Good afternoon, Madam Chair, members of the committee. Heidi Hertz representing Reyes. We provide outpatient radiology services in Northern Virginia, Roanoke, and Central Virginia, and we support the bill. Thank you.
Madam Chair, members of the committee, James Pickrell representing the Virginia Radiological Society. We are the professional society for Virginia's radiologists. And for all the reasons stated previously, we support the bill.
Thank you very much for those comments. Is there anyone who would like to speak in opposition to the bill? Mr. Gray, you have the floor.
You'll be seeing a lot of me. We've had 33 health insurance bills this year. So that means 1 in 3 of you have a bill for me to talk about. On this particular bill, I'm not naive about where the bill's going, but I do want to remind you that if you continue down the path of waiving cost shares by disease, you will have a long list of diseases in front of you requesting a waiver by cost share. You can't waive them for everyone. That's the first observation. The second one is this is not by need. You're waiving every cost share, regardless of your ability to afford it. Wealthy people can afford their cost share. They will not be paying their cost share. Guess where all those cost shares go? They go to premium, which means you're increasing the price on everyone. Means testing is important. All of our coverage is means tested through our society. That's how we do things. You should keep that in mind. Third and last, House Bill 2611 has already been introduced, which waives cost shares for anyone with cancer of any type. At some point, you've got to get your hands around how you're approaching this. So just keep that in mind. Other than that, I don't actually have too much to say about your bill in particular.
Thank you. Thank you very much. We're going to go online. We have 3 folks who would like to speak. First up, Leanne Keene, if you could please turn your camera on. And you are, it is your turn. You have the floor. Thank you very much. Please state your name and your affiliation.
Thank you so much. I have several affiliations. I am a force volunteer. I am a BRCA mutation carrier, which means I have the highest risk of breast cancer. And I work specifically with women who are deemed high risk for having breast cancer. So I have personally felt the impact of the financial burden of having a high risk of breast cancer. And I have seen patients who have put off care far longer than they would have if not for the consideration of cost. Specifically, one study that just recently completed that really spoke to me was completed by the National Cancer Institute that looks at state cancer profiles. And in Virginia, the 2 maps that stood out most to me are the cancer death rates are the highest in the counties that have the highest food insecurity rates. And so that lets you know that there's a big disparity in people who are obtaining care earlier in the treatment cycle. Thank you.
Thank you very much. Next, we have Priti Shah. If you could turn your camera on, note your affiliation, and just a reminder at the top that you have 1 minute to share your support. Thank you very much.
Thank you so much, Madam Chair, and the rest of the committee. I'm in clinic. I'm a breast imaging radiologist, so I really appreciate the opportunity to provide testimony virtually today. I just wanted to add a comment to Ms. Fitzgerald's analysis of the ACS white paper that came out. It was estimated in that paper that 70.4% of insured patients had out-of-pocket costs for follow-up breast imaging tests in 2023, and those with the highest deductible plans, of course, had the highest out-of-pocket cost. Another recent study has shown that 21% of women will skip additional imaging if they face an out-of-pocket cost. And I see this in my practice literally every day. I submitted some public comments, but I do have some patient examples to supplement that. Patient that turned down an offer to perform a same-day biopsy because she was still paying off $700 from her diagnostic imaging and paying off bills from her daughter's hospitalization. A patient declined having a screening MRI for her high-risk status because she was still paying off her screening MRI from 2 years ago. A patient who has insurance that was quoted $3,300 out of pocket for a diagnostic ultrasound that she can't afford, so didn't have it.
Thank you.
Other patients
Thank
that
you.
cancel their appointments.
We've gotten to our.
Hearing me out.
Yes, thank you so much for sharing those specific examples as well. Thank you for testifying today. Our next person is Ms. Katie Page. If you would go ahead and thank you. Go ahead, you have 1 minute.
Thank you, Madam Chair, members of the committee. I'll say thank you also for your votes for House Bill 1923. I was here, but not here. I'm speaking in support on behalf of the Virginia affiliate for the American College of Nurse Midwives. I am a certified nurse midwife providing reproductive health care for women beyond menopause in my practice, and echo the comments of my clinician colleagues of the extent to which my patients will decline additional screening tests if they are high risk or if their screening test finds an abnormality because of the fact that they have cost sharing. So midwives are in support of this bill to meet the needs of the patients that we serve.
Thank you very much. Okay, seeing no other comments online, would you like to have last words, final words, Delegate?
Thank you, committee. I think the examples of people not wanting to get their follow-up, diagnostic screen because they have an outstanding bill are incredible. This bill is for everyday people who need to budget, who can't have a surprise out of pocket $700 come across their checkbook. They're choosing between groceries and their own health. And we know women a lot of times will always choose their children and groceries and other people rather than themselves.
Thank you, Delegate. And I also want to just say to the delegate, thank you for your hard work over several terms to try and move this forward, this important issue. And I am hopeful that at some point we'll get this fully right and fully balanced and fully fair. I do know that we will there's a letter to send this to appropriations, but also as the committee works on motion, I want to say that once we rolled in Delegate Keys-Gamarra's bill, it is now a substitute bill. So with that, the committee works on motion.
Madam Chair.
Yes.
I'd move to report and refer to appropriations with substitute.
Second, it's been properly moved and seconded. If we could open up the rolls and place your votes on the board. Okay, this report and referred with substitute to appropriations by a vote of 7-0. Thank you very much, Delegate. Okay, next up we have HB 2069, Delegate Garrett. Delegate Garrett here? Oh, there he is. I see it. Delegate Garrett, we have two bills by you, so we'll do them both at the same time. Start with HB 2069.
Thank you, Madam Chair and members of the committee. HB 2069, I think it's kind of one of those ripped from the headlines bills. It deals with preparedness and fire safety. I don't know, and I'll get ahead of my skis a little bit here, but on purpose. I'm not sure I've ever had a bill that was supported by such a broad bipartisan group of folks. The Virginia Fire Chiefs Association, the Virginia Professional Firefighters, the Virginia State Firefighters Association, the Virginia Association of Governmental and EMS Administrators, the Virginia Association of Volunteer Rescue Squads, Fire Prevention Association, International Association of Arson Investigators, Virginia Association of Hazardous Materials Response Specialists, EMS Councils, Emergency Management Association, Fire Service Councils. I think, heck, VACO's here in support of the bill. And so why? Well, we all have watched and been taken aback as 46,000 acres of California burned. And we've heard stories about lack of preparedness and resources not made available. And we've seen the tearful accounts of people who lost the only home that they'd ever known. And certainly no human individually is responsible for the Santa Ana winds, but we do know that in a world where calamity may arise, preparation is the key to minimizing the results. Decades and decades ago, Madam Chair, the General Assembly created the aid to localities provisions of the code. And what they do is help our localities, specifically in this instance, with fire and rescue equipment and to meet the needs for the public safety of the citizens of those communities. This came to my attention because I live in a rural area, and Appomattox County specifically, not to single them out or pick on them, is one of the lowest performing localities as it relates to state and federal qualifications to maintain fire and rescue services. And a large part of that is because we've created, the collective and royal we, a scenario where our localities are burdened each year, regardless of which party's in power, by additional unfunded mandates. And so they have to stretch that dime, that dollar, just that much further to meet their core essential functions. But this isn't about exclusively rural localities. Let's speak to Cumberland, which I also represent. One new pump truck cost about $750,000. The amount of money that aid to localities sends to Cumberland County is about $50,000. Now, the county is wholly responsible for about 99% of their budget as it relates to this important fire and rescue equipment. But the state recognized in the 20th century that aid to localities was relevant and important source of generating the resources that these localities need in order to meet their public safety demands. And because I understand that while I represent largely rural localities, but not everyone in the General Assembly does, I just randomly picked Manassas Park as a not rural locality. I think that one of the members of this committee represents, not accidental, right? So the oldest vehicle in the fire inventory in Manassas Park is a 2008 Pierce attack pump truck. It would cost just under $1 million to replace that piece of equipment, which is 17 years old, which is very old, by the way, in the fire safety community. And if you took Manassas Park's ATL money and devoted it exclusively and solely to buying that one vehicle out of a dozen or so that they run out of Manassas Park, it'd take 15 years to pay for it. So you see my point, and you see that this cuts across all swaths of Virginia, whether rural or urban or exurban or suburban, and this public safety issue is one that we all understand too well based on the headlines that we've witnessed recently. The only other thing that this bill does is expand the breadth of the areas that ATL monies can be used for by localities. That means that what I think everybody here recognizes is the people in Manassas Park or Appomattox or Cumberland know what their most pressing public safety needs are, and if it's for a fire station, they should be able to spend it there, and if it's for a fire truck, they should be able to spend it there, and if it's for counseling for fire professionals who have mental health issues arising from having to literally, in the case of Cumberland County, carry the bodies of 3 children under the age of 10 from a ditch where they were dead to a truck, they should be able to spend the money there too. So those are the two things that this bill does. Now, we're going to hear later on today from a bunch of people who support this bill and from some people who oppose it. And the people who oppose it are largely my friends outside of this room, but they represent primarily the insurance industry. And they're going to tell you that there's the potential for retaliatory tax against Virginia businesses because we have changed our rate for the first time in 30 years to address ATL. They're right, but they're not. Here's what else you need to know. There is a code section currently, 58.12510, that solves the problem by allowing for insurance companies to claim tax credits for retaliatory taxes claimed by other states. That's number one. And number two, in almost all instances, but not all instances, there is an exclusion for fire service-related taxes from retaliatory tax collections. So there's not always, and the folks who, again, who are going to speak against this bill are doing their job representing the insurance industry. My job is to represent my constituents. And I don't have a problem with the insurance industry. I'm glad they're here. But I think we'll go full circle as I wrap up for now. We started out by talking about the LA fires and their impacts on real, living, breathing human beings, and folks who lost, in many instances, the only home they've ever known. Let's conclude with the LA fires as well. Shortly before the LA fires, one thing that we saw was the insurance industry canceling policies. Because they're evil? No. because they can do math and they understood that there was a lack of preparedness that created an enhanced risk for excessive damage based on the conditions that they saw. And one thing that this bill does, among many, is help to reduce the lack of preparedness that we have in our communities. And I want to stress yet again, whether it be Cumberland or Manassas Park, whether it be Fairfax or Brunswick. So with that, for now, I will conclude, Madam Chair.
Thank you, Delegate. Are there any questions from members of the committee? Okay, seeing none. If there are folks in the room who would like to speak in support of the bill, please come forward.
Good afternoon, Madam Chair, members of the subcommittee. My name is Jeremy Bennett, representing the Virginia Association of Counties, VACO. I would like to thank the patron for his leadership on this issue. VACO has participated the past 2 years in 2 work groups with various stakeholders in fire and EMS community and with VDFP. We've seen that the call volume and demand for emergency services has consistently gone up. Volunteerism across the state has gone down, and state funding has remained level. Obviously, the majority of funding comes from localities, but in order to meet these increased demands, and one of the recommendations of the work group was to find additional state funding to support localities. So we're very much in favor of this legislation. It's a constant refrain we hear from our membership across the state. And again, I urge you to support the bill and thank the patron for introducing it.
Thank you.
Madam Chair, members of the subcommittee, David Bailey, speaking on behalf of the Virginia State Firefighters Association. This program, the Fire Programs Fund, started 40 years ago. And sometime between 85 and 94, it became 1%. If you check back as far as LIS will take us back to 1994, it's been 1%. The opposition that you will hear today is the same opposition who, I'm told, opposed the bill when folks like Earl Dickinson and Bob Ball and other leaders in the General Assembly got this established. There is certainly a connection between the fire issues and the insurance, but also from your own jurisdictions that the firefighters do more than just fight fires. They often are the ones that are right there when you call 911, and the costs continue to go up. So we urge you to support this bill. Thank you.
Thank you. Is there anyone that would like to speak in opposition to the bill? If so, please come forward. Yes, Delegate.
Madam Chair, I made a mistake, and I like to own my mistakes. There is a substitute language that we need moved, and I'd be grateful if somebody would make the appropriate motion. I apologize.
Okay, substitute's been moved and seconded. And we need to vote on that. Both all in favor? All opposed? Okay. It's been properly moved and seconded. Go ahead, you may come forward.
Thank you, Madam Chair, members of the subcommittee. Karen Addison, representing American Property Casualty Insurance Association. We are in opposition to the bill. You've heard a lot about the opposition. I think it might just be me. But I just want to point out this is a tax increase that will be borne by the consumers. We all agree that fire and EMS services are very important. We want them to be there when we call them. But again, this is a tax increase to pay for that to the insurance premiums. And Delegate Garrett mentioned the retaliatory tax. So we do think that that will disproportionately affect Virginia-based companies. So if you could keep that in mind. Thank you.
Thank you.
Madam Chair, question for the witness.
Yes. Delegate Sullivan, you have the floor.
So I see that the impact statement indicates that the likelihood is that this is going to raise somewhere over the next several years between $70 and $100 million. And you describe this as a tax increase. What's that mean? What's the difference on the insurance companies from 1 to 1.5, and how's that going to affect, will that affect Virginia consumers?
Yes, sir, Madam Chair. This will affect the premium. So the tax is on the premium, so it'll be for a 1 to 1.5% increase, and that cost will be borne by the consumers because it will be passed on to the consumers. And I don't have the numbers in front of me.
Follow-up question. So does this tax appear on a insured's tax bill, just gets passed right through?
Yes, sir.
Thank you, Madam Chair.
Yes. Anything else you would like to share? Okay, thank you very much. Okay, do we have any?
I have a question.
Yes, Delegate Sullivan.
Is the administration in the room? Does the administration have a position on this bill?
So Spencer Willett from Fire Programs is here, and he worked in conjunction with Delegate Sickles on the study that recommended this bill. The administration has no position, I don't think, but Spencer can answer questions.
Thank you.
Madam Chair and members of the committee, I'm Director Brad Creasy from Fire Programs, and the agency has no position, but I'd be glad to answer any questions technically that you have. I will, just to build on the delegate's case, we just had a study on fire and EMS needs across the Commonwealth conducted last year, and that was done by the VCU, and it showed that 97% of the financial burden is placed on the localities throughout the Commonwealth when it comes to fire and EMS.
Delegate Sullivan.
Sir, this is a weird question, but why doesn't the administration have a position?
Sir, I can't answer that. I know that by policy, we were just told that the agency was to take no position on it. But again, these are our stakeholders. We understand the importance of the aid to localities funding. Our agency distributes that. I'm not sure that I understand that there's anything on your premium when you pay your insurances that it's a tax per se. If you read the code, it just says that it's based on 1% of all the gross in those 5 categories that deal with fire protection. So I'm not sure.
Follow-up question.
I agree with.
Delegate Sullivan.
Thank you. And appearing on the bill, or does this appear on every type of casualty insurance? In other words, my homeowners, a commercial office building, every kind of casualty that covers fire?
Fire protection, it's 5 categories. So automobile, your homeowner's insurance. I think there's marine for like boats. And the other 2, I don't come to mind. But again, it's 5 categories is what.
This would only go on one of the 5, or would this go on all?
This goes on all 5.
All 5.
All that deal with any type of fire protection.
So I have fire protection on my car. I probably didn't even know that.
Yeah. Yes, sir, you do.
And so that's, so any insurance policy essentially for your car, your boat, your house, your building, your business.
Mm-hmm. Yes, sir.
Thank you, Madam Chair.
Thank you, Delegate Sullivan. Oh, goodness. Any other comments or questions from the committee members? Okay, thank you very much. Okay.
Madam Chair, if I'm correct, there are a number of people waiting to testify online. I just wonder.
Yes. Yep, we're going to move there next. Okay. All right, online, we have Mr. Alan Baldwin. If you would, thank you. Go ahead and state your name and affiliation, and you have one minute. Thank you very much for coming today. Oh, that's not Mr. Baldwin? Oh, it's Van. Okay. All right, then Mr. Cooper, Vance Cooper, go ahead. You have the floor. You have 1 minute. Please introduce yourself, full name, and affiliation. Thank you for coming today.
Thank you for letting me testify here virtually. Can y'all hear me?
Yes, we can. Thank you.
All right, fantastic. My name is Vance Cooper. I'm the current president of the Virginia Fire Chiefs Association. And I don't know that I could do any better than everyone else has already done in speaking in favor of this. Would like to add a couple items to what's been said. 3 years ago, the fire service came to the legislator and said, we need money. We're hurting. Things have gotten so expensive and we can't keep up. And it's for real things like fire stations and fire trucks and turnout gear and SCBA and hose and ladders. The real stuff being used that was alluded to out in LA. But we're using it here too. It's so expensive. It's very difficult to keep it up, and it has to meet certain standards. Secondly, I'd like to say then we did a House Bill 2175 study that identified that we fell into those same categories of needing help in those areas of stations, heavy trucks and such. We just concluded the VCU study that you guys sanctioned with the Wilder Center. 97% of the funding is local. The other 3% comes from different grants, one of them being ATL. And every single one of those are also funded by individuals through their federal taxes or fees that they pay with their registration or their license plate.
Thank you.
These are all paid for 100% by individuals.
Thank you very much, Mr. Cooper, for your testimony today. Okay, would you like to, any final comments or questions from members of the committee? Delegate Sullivan.
Thank you, Madam Chair. I don't know if this is for you, Delegate, or maybe it's from the gentleman from the fire. How's the money distributed?
So I would love to carry a bill that revised ATL, but I'm aware that that might not pass this body, and I'll tell you why. Right now, ATL is determined by population, period. And so this is why I picked Manassas Park and not Fairfax. Cumberland County has 297 square miles. Manassas Park has 2.6. And that's okay. In any event, Manassas Park needs fire trucks, and if it takes 15 years, if that's all you use your ATL money for to pay for one, then we might ought to relook at how we do this. I think that the formula should be changed, but that's not going to happen in this legislature. So how about we recognize that there's a need for enhanced fire safety, that there's a need to bring our public safety policies, and specifically but not exclusively ATL, into the 21st century, as it literally has not been tweaked for 30 years. And so that's how it's distributed right now as population. I think that should change, but that's not what this bill does.
Thank you, Madam Chair.
Thank you. I have a question for you. What is the fizz on this?
So the fiscal impact is, I think, the price of a position in the fire safeties program. However, the estimation is that this would more than pay for itself vis-a-vis the revenue raised. I think 0.25% goes direct to localities, and then there's another pot of money that would pay for that. So we're prepared to. I mean, it literally will generate more revenue than the fiscal impact. That was probably the least articulate thing I've said. But
Yeah, thank you. I'm actually looking for the dollar figure for the fizz.
sorry.
The fiscal impact was just for the one position to help distribute grants, which we already have one person there, but understand that that's not general fund dollars. All of these folks in our agency are special fund that is derived from the Aid Localities Fund. And so 75% by code, 75% goes back to localities, 25% operates the agency. So we'll be able to absorb this with the increase.
You anticipate one new employee?
One new employee, yes.
Thank you. Okay, thank you. We want to do some math up here.
Madam Chair.
Yes.
One thing that you didn't ask, I just wanted to mention, and I know you probably have the numbers in front of you. It shows what that impact looks like, the projected numbers over the next 5 years. This year, $40 million was distributed to localities. So that should give you a baseline of what this would take it to. This year, we distributed $40 million to 316 localities.
Thank you.
But sir, beyond population, as the delegate said, what's the criteria? How do you decide who gets money and who doesn't?
That's been a good discussion with our stakeholder groups for quite some time. But right now, it goes to localities. It's all based on population. If you do not meet the minimum population, counties and cities get 30,000 and towns get 15,000 if they do not meet the minimum population, and then everyone else is based on population. So for example, Fairfax County last year, which the biggest population, got 4.9 million. Virginia Beach was second with 2 million. the majority of localities, Roanoke City is probably in the 300,000 range.
Cumberland gets 45 and Manassas Park gets 75.
So this is a formula that doesn't take into account the age of the equipment?
That's correct.
But most localities are trying to meet the NFPA standard, which is replacing apparatus at 20-year increments. Okay. What you will see in some of the more stressed, fiscally stressed areas in like Southwest Virginia, they are literally operating 40-year-old equipment that was donated to them from Northern Virginia agencies. So, but most across the Commonwealth, most departments are trying to meet the NFPA standards in order to get these AFG grants that Chief Cooper mentioned, of the federal grants that also subsidize their funding. They have to meet certain standards, and the NFPA standards require them 20 years or less.
So if I might anecdotally to your question, because this is just a story I want to tell for my public safety folks. Cumberland County had a metaphorical gun battle over an ambulance last year, and they ended up buying getting 2 used ambulances because they couldn't afford 1 new one. And I commend that Board of Supervisors for making ends meet, but that's just real.
Thank you, Delegate. All right. Would you like to have last words before we move to vote?
No, Madam Chair, I'm grateful to the members of the committee. I just ask you to, 30 years is a long time, and the reality is that things have changed to the point where we need to do something differently. Again, the fiscal impact, the total anticipated is $118,000 year over year. We're looking at $40 million, and I'm rounding here, distributed last year with this bill to be about $60 million. So you can do the math there as to the total amount that's not going to our first responders. So thank you.
Thank you, Delegate Garrett. All right. Committee moves by motion.
Madam Chair,
Yes.
I have a motion at the appropriate time.
Yes, you have the floor.
Thank you, Madam Chair. I move to report
With substitute.
with substitute.
It's self-funding, so it doesn't have to.
Second.
Okay, it's been properly moved and seconded with substitute. If we go ahead and put our votes on the board. This report's with substitute by a vote of 6-1. Thank you, Delegate Garrett.
Madam Chair, members of the committee.
I want to go at ease for just a moment.
Yes, ma'am.
All right, Delegate Garrett, you have a second bill up before us, HB 2073.
Yes, ma'am. Thank you, Madam Chair. So there is an amendment in the nature of a substitute, and the best thing to do with mistakes is...
Second, it's been properly moved and seconded. So
Thank you,
all in
Delegate
favor? All opposed? All right, substitutes accepted. Please proceed.
So what this bill does is it creates an avenue to report allegations of debanking. Debanking is a relatively new word, and it is a process wherein a financial institution refuses to do business with an individual based on a belief that they might have that's counter to what is either held by that institution or by some political entity, what have you. Now, we've heard of redlining. It's horrible. We try to address it, but it still sticks its ugly head up. We've heard of blackballing, and debanking is simply the same sort of thing, where people or entities are punished by virtue of their affiliation with an action, event, or idea. And you can say, well, who does it happen to? And certainly it's been prominent in the communities of faith, where people whose faith values don't align with the current orthodoxy. It's been prominent in particular business ventures, people who our firearms dealers, et cetera. But this practice knows no bounds, and I will use as an illustration, while going out of my way to not make this political, the son of a former president who was unable to get a bank after his name had been used, bank account, after his name had been used in particular political contexts, right? So this cuts across party lines. It's an important practice that shouldn't exist. And what this bill does is simply says that if you allege that you have been debanked by virtue of who your dad is or mom, or by virtue of what you do for a living, or by virtue of some other protected right, that there is a place to report it to, and specifically the BFI, the Bureau of Financial Institutions. You have no idea, Madam Chair, how hard it has been for me to stop saying FBI, the BFI, so that we can gather data on this and determine if in fact it is a problem at the state level here in the Commonwealth. The banking entities oppose this bill by and large, and I understand why, and the why is that they're subject to a myriad of regulations, both state and federal, and this creates another hoop for them to jump through in order to comply. That is why there's an amendment in the nature of a substitute. We have done everything we can, and I hope that when they come to speak to this bill, they concede that to make this as palatable as possible. But while this sort of arcane practice seems to profligate, did I use that properly? We need a mechanism by which to track it, and so that's what this bill would allow for. It would allow for someone who alleges they've been debanked to have a route to report it, and specifically to what already exists, the BFI here in Virginia, because we want to get a handle on it so that it doesn't become more common. Thank you.
Thank you. Are there any questions from members of the committee? All right, moving to the floor. Is there anyone in the room that would like to speak in support of the bill? Anyone in the room that would like to speak in opposition to the bill?
I really wish they would have spaced it out a little bit more so it didn't look like it.
Madam Chairman, members of the subcommittee, Matt Bruni with the Virginia Bankers Association. While we appreciate the patrons' improved substitute over the original version, we still oppose the bill. This really is a solution in search of a problem. There are not banks that are using this so-called social credit rating. In fact, there are no credible examples of individuals being denied financial services based on any of the criteria listed in the proposal. Yes, banks can choose, and they should be able to choose who they serve subject to the real and existing anti-discrimination protection laws already in place. And government definitely shouldn't be telling financial institutions they cannot deny services to those who pose identifiable risks the bank chooses not to take on, including related to national security or criminal enterprise concerns. This effort undermines banks' requirements in those spaces as we have to report things like anti-money laundering and terrorist financing to federal authorities. Those may be the reasons they move on or deny a customer, but those individuals could then turn around and make a complaint based on any of the subjective or unsubstantiated criteria in the bill. I know that's not the patron's intent, but it is the very real potential consequence of going down this path. There's no reason to enshrine in Virginia code a definition of debanking that undermines the real anti-discrimination protections in place, nor should we be moving the Bureau of Financial Institutions into a political conspiracy complaint box. We urge you to reject the bill.
Madam Chair,
Sir.
could I ask the
Well,
question?
if you would, yes. Yeah. Please go ahead, Delegate Wilt.
Thank you, Madam Chair. So as a consumer, and this happens to me, I get turned down and I feel like I've been unjustly treated through that process. Do I have recourse currently? Is there some process that I can go through to submit a complaint and try to get satisfaction?
Madam Chair, Delegate Wilt, yes, in a number of different ways, depending on what the situation is with the financial service product that you're doing. If it's a deniable loan, the bank by law requires you to submit an adverse action, saying why we denied you. It was your credit score, you didn't have sufficient, assets, your debt to loan. And so there's already on the lending piece, yes. I want to go into the bank and set up an account, or I have an account and the bank is asking me to close it. Yes, if you have a complaint, you can go to the Bureau of Financial Institutions. They do take complaints. The federal regulators take complaints. The Consumer Financial Protection Bureau has a wide, extensive database that they encourage the public to submit complaints. So there is already mechanisms generally on complaints. Our concern is specifically putting in these, criteria that are not existing. I mean, you can complain about anything you want. Does that mean the bank did something wrong? No.
Madam Chair, follow up.
Delegate Wilt.
Thank you, Madam Chair. So if I'm understanding correctly, there's a pretty narrow band of reasonings that you can turn me down. I mean, primarily you're going, you have to justify based, I don't know, I got bad credit or whatever. It's got to be along those lines. How far can you stray from that? What all can you turn me down for, let's say?
Madam Chair, Delegate Wilt, I think it's important to talk about what we cannot deny you for. And I think that's, you have the fair housing, the equal opportunity, Reg B. There is a number of existing anti-discriminatory, the delegate raised, redlining. There are now in place things that make all that illegal and subject to fines and regulatory penalty. So there are things we cannot deny you. There are reasons, that a bank can deny a loan. They already have, we're not looking for more deposits, so we don't want to, add more, more accounts out there. They can make that business decision. And I think, too, this credit, there is a piece in the bill that does say for financial reasons, but there's more than just financial risk reasons. We talked about, if there's a national, there's criminal activity going on that the bank can't sit there and publicly say, hey, Matt's done something wrong, but I've filed, 30 SARs, the suspicious activity report. We can say, Matt, we don't want you as your customer anymore. We can't say that out loud in the public space so that then that person goes around and say, well, I'm going to complain to the Bureau of Financial Institutions because I own a gun or I, have a certain political stance or religious. You can't tell the full story on that. I hope that answers your question, Delegate.
Delegate Wilt, thank you. Thank you. Yes, please.
Madam Chair, members of the committee, Corey Connors with the Virginia Association of Community Banks. As the delegate noted, there is no aspect of banking that is not subject to extensive federal regulation. This includes requirements to prevent money laundering and to counter terrorist financing. Compliance with these federal regulations are necessary for a bank to be insured by the FDIC or to receive access to liquidity from the Federal Reserve. For that reason, we oppose the bill.
Thank you.
Madam Chair, Rob Bohannon, representing the Virginia Credit Union League, will associate our comments with the previous two speakers. Just should note, Florida passed a similar bill last year that created a hotline for such complaints. There were no complaints filed on the hotline that year. And the other piece of this, I think, that I would add is that the concern is that the credit union bank or whomever would face potential lawsuits from someone who was denied, and they would then say, well, it was because of these reasons, which it may not have been about those reasons. It were some of the other reasons that were stated before. So thank you.
Thank you. Any other comments from folks in the room? Okay. Seeing none, we're going to move to online. And we have one person online, Mr. Brian Knight. If you would go ahead and turn your camera on. State your name and affiliation, and please share your comments, keeping them to 1 minute. Thank you and welcome.
Thank you so much, Madam Chair and members of the subcommittee. My name is Brian Knight, and I'm a senior counsel at the Alliance Defending Freedom, speaking in support of the bill. Access to financial services are essential to functioning in a modern society, and financial institutions enjoy an unprecedented amount of power and protection granted by government, including barriers to entry for competition, exclusive access to government services, and protection from failure quite frequently. We know that they've been targeted as a means to suppress speech or to impose de facto regulation. A few years ago, there was a push to get banks to cut off financial or fossil fuels or gun companies or whatever. That was quite explicit, and some banks, such as Citi or Bank of America, quite explicitly changed their policies with an eye to changing downstream activity. And contrary to what someone earlier said, the Virginia Christian Alliance here in Virginia lost their bank account under dubious circumstances after being listed as a hate group. But to be clear, this is a concern that applies across political spectrums, and we think that this bill is an appropriate step forward to gaining more transparency.
Thank you. Thank you very much, Mr. Knight, for sharing your comments here today. All right. Any final comments from members of the committee? No? Okay, would you like to have final words?
Yes, ma'am, Madam Chair. Thank you. And thanks to Mr. Knight online and the other people who've come to me about this bill. I hold in high regard the folks who spoke against this bill. But I believe it was Shakespeare who originally said, "Methinks thou doth protest too much." This bill, as it is currently drafted, simply creates a mechanism by which one could report an allegation of debanking so that we might investigate it. And so, if there is no debanking, why is there opposition to creating a mechanism by which one could report an allegation of debanking? Right? I get it, and I understand that they're doing their jobs, but if this isn't a problem and this has no fiscal impact, and we can literally cite groups in the Commonwealth of Virginia who have credible arguments that they've been debanked, why not let them have an avenue? So that would be my final comment, Madam Chair, and thank you.
Thank you very much. Okay, this committee works by motion.
I move to report. What's up?
Is there a second?
Oh, well.
Second? Okay, it's been properly moved in.
I have a substitute motion, Madam Chair.
Delegate Shin?
I'd move to pass this by indefinitely.
There's been a motion to pass this by indefinitely, and it's been properly seconded. Let's go ahead and record our votes on the board. Yep, I was trying to give time. Sullivan. All right, the motion to pass by indefinitely by a vote of 4-3 is approved.
Madam Chair, members of the committee, thank you guys immensely. Have a great day.
Thank you. Next up, we have Delegate Shin. You may feel free to, I'm sorry. You may feel free to stay at your chair or go to the front podium at your discretion. Actually, I'm going to pause because I thought I had the last page of my bills and I don't, so I'm going to do committee members last. So I'm going to have Delegate Austin for HB 2097 come up, and then we'll do Delegate Waxman. Thank you.
Thank you, Madam Chair and members of the committee. I'm before you today with HB 2097, and I have an amendment in the nature of a substitute.
Move to adopt a substitute.
Motion to move and adopt a substitute. Is there a second? There's a second. Okay. All in favor? Aye. All opposed? All right.
Thank you, Madam Chair. HB 2097 is a prostate screening bill. It increases access to crucial health services by expanding coverage for prostate screenings in the Commonwealth. Virginia has the highest prostate cancer incident rate and the second highest mortality rate for Black men in the nation. Because it is often asymptomatic until it becomes metastasized, screening helps to detect the disease early when it's most survivable and the least costly to treat. The current cost-sharing environment means that those who would benefit most from early prevention are not being served. HB 2097 seeks to address this by removing out-of-pocket prostate cancer screening costs for high-risk men. It does so by expanding coverage of prostate-specific antigens known as PSAs and exams for those who are at higher risk and determined by the American Cancer Society's guidelines. Standardizing annual screening coverage for individuals who are at an average high or elevated risk of prostate cancer, and ensuring consistent benefits for insurance holders for these screenings. HB 297 is identical to Senator McPike's SB 1314, passed unanimously, and it's recommended by the Health Insurance Reform Commission. Thank you.
Thank you. Thank you, Delegate. Any questions from committee members? All right, moving to folks in the room. If there's anybody that would like to speak in support of the bill, please come forward. Go ahead and state your name and affiliation, and just reminding folks that you have 1 minute.
Thank you, Chair Maldonado and members of the committee. My name is Allie Manson. I'm with Zero Prostate Cancer, and I've submitted written comments to each of you explaining why prostate cancer screening is such a critical step in the diagnostic process, why even a small copay can be a barrier to screening, how Black men are at a disproportionate risk of prostate cancer, as well as how very little this will cost anyone, including with insurance, to remove this one barrier to care. But and those are all good reasons, right? Those are very good reasons to support this bill. It's why HERC recommended it. However, I want to tell you something that's not in my written comments. Of the 9,040 Virginians who will be diagnosed with prostate cancer in the coming year, many of them will be lucky, right? They'll have no symptoms. They will be diagnosed because of a routine blood test that said they were at high risk. They'll receive treatment. 5 years from now, they will still be working, playing, enjoying time with their families. But some of those people will be like Paul. Paul was 54 years old when he visited his doctor with back pain. Oh, crap. He was diagnosed with advanced and aggressive prostate cancer. He and his wife had just launched their daughters into the world. They graduated from college, started their lives. They were planning for travel, weddings, grandchildren, all that fun stuff. Instead, they spent the next 14 months on an intensive regimen of chemotherapy and hormone therapy. At 54 years old, after 14 months of treatment, Paul died. His wife and his daughters have dedicated themselves to channeling their grief into making sure that no one else's family experiences what they did. And we know that early and appropriate screening is absolutely critical to ensuring that more people are in the lucky group. So I ask for your support.
Thank you. Thank you very much. And as the next person approaches, just reminding folks that the substitute conforms the bill to the recommendations of HERC. Thank you. Welcome.
Well, Madam Chair, members of the committee, Kelly Fitzgerald, again representing the American Cancer Society Cancer Action Network. We are supportive of the bill. I think really, I know today we've had a lot of talk about cost sharing for cancer, and what I would say is that from our perspective, we are not only thinking about the quality of life and extended life of someone, but also the money that can be saved by early detection. So, just wanted to leave you with that. So, thank you.
Thank you.
Madam Chair, Doug Gray, on behalf of the Virginia Association of Health Plans, we're supportive of this legislation. It is reflective of the preventative services required to be offered without a cost share at the federal level.
Thank you. Yeah. Whoa.
Can you come back up here so I can get this on?
It'll last for a moment. All right. Did anybody have any questions on the committee before I?
Move to report.
I think we still have to give opportunity. We have some folks online. And just wanted to confirm, is there anybody in the room that would like to speak in opposition to the bill before we move to online? Okay, seeing none, we're going to move to online. And we have Mrs. Carrie Short. If you could turn on your camera, identify yourself and your affiliation. Hello and welcome. Thank you for joining us today. And you have 1 minute. Go ahead and begin.
Thank you. Thank you, Madam Chair, members of the committee. I'm Carrie Short. I'm the Executive Director of the Shellhammer Urological Research Foundation in Virginia Beach. As a nonprofit that does community outreach for prostate cancer, we want to remove all barriers that prevent men from getting screened. It's the most common cancer among men, and it has the same incidence rate as breast cancer. But screening for men most at risk is often not covered. When the SURF Foundation plans a community screening event, we're quoted $31 a PSA test. And this is a simple blood test. It is not a follow-up test. It's not a fancy diagnostic. So it is very important that men at risk be covered by their insurance. So the SURF Foundation can focus on covering men who fall between the cracks. We operate in Hampton Roads, which is home to 2 of the localities with the highest mortality rate for this type of cancer, which is most curable. So with 1 in 8 American men receiving a prostate cancer diagnosis in his lifetime, 1 in 6 if they're men of color, you probably know a man who has received a diagnosis. But because I live in Norfolk, I know men who have died from prostate cancer. It's one of the 2 localities with the highest mortality rates. It doesn't need to be deadly because if it's detected early, it is one of the most curable. So I'm asking you to support House Bill 2097 because it won't just help insured men, it will help foundations like me and charities like the Surf Foundation to help more at-risk men. Thank you so much for your time.
Thank you. Thank you for testifying today. All right, seeing no others online, would you like to have the last words before we go to vote?
No, ma'am, thank you.
No. Okay. All right, well, this committee.
Now I move to report. Second.
All right. With substitute.
I move to report the substitute. Yes, ma'am.
And second. Thank you very much. It's been properly moved and seconded with substitute. If we could go ahead and open the rolls and place our votes on the board. Okay. HB 2097 has been reported with substitute 7-0. Thank you very much, Delegate. All right. If we could have Delegate Waxman please join us for HB 2106.
Thank you, Madam Chair, members of the committee. I'm here to present HB 2106. This bill actually addresses a problem that was brought up at the last session. I think some people may remember that we passed a bill relating to sickle cell and the prescription monitoring plan. It exempted the sickle cell physicians from having to look at the PMP plan. When I had some questions about that bill, if you may remember, and I talked to the patron, and the problem she was trying to solve was someone going to a pharmacy over the weekend with a narcotic prescription for somebody that was in sickle cell crisis. Sickle cell, when you get in crisis, is extremely painful. And the patron noted a study, a 4-page study looking at CMS data that indicated there were several people that they felt died because they couldn't get adequate pain management, had that extra stress level. When that really perplexed me because I didn't understand how the PMP process worked. So I actually found that study. And the study used a term that wasn't prescription monitoring plan, it was prescription or medication management plan instead. And trying to figure out what that meant, I realized it was an insurance issue. Insurance plans have this thing called a drug utilization review. When a pharmacy gets a prescription, fills a prescription, it goes electronically to the pharmacy. And if there is several actions that PBM or a prescription company will send back a block that tells the pharmacy you can't fill that prescription without contacting the physician and getting the physician's office to justify an override. Now, going back to the problem from last year, it was a weekend. There was no way that pharmacist could contact the doctor to get the override for the insurance plan so that patient could get that narcotic prescription that they needed to get rid of their pain. Sickle cell patients, because they have these crises periodically, normally the physicians will do short-time narcotics for those crisis situations to get them out of pain. So they're taking shorter day supplies and are getting prescriptions filled more often. That runs a counter to one of the insurance company's common plans is if they get, say, more than 5 narcotic prescriptions over a 6-month period of time, it flags them for that drug utilization stop that the pharmacist can't override. What this bill does is just simply say that if a pharmacist gets one of those DURs, the insurance plan has to allow the pharmacist to fill it without going to the process of getting the doctor to do the override for sickle cell patients only.
Thank you, Delegate. Are there any questions from the committee? Okay. I do have a question. I certainly think that many of us may know people who have sickle cell anemia or have people in their lives with them. And the one thing I was curious if you could help us explain from an how to operationalize it, excuse me. Unlike when you go to a medical visit, there's an ICD-9 code, a CPT code to understand what the purpose of the visit is, but with prescriptions, there is no diagnostic code. So certainly this can waive by having to waive that override, but how will you know that this is for a sickle cell patient? How will you know that the medication is specifically for that purpose? Since the doctors don't have to say that, because the medication presumably could be used for a variety of things.
Right, that is an excellent question. Most pharmacists, certainly in my pharmacy, I sort of knew who my patients were that had sickle cell. We receive more and more prescriptions now electronically. When those prescriptions come in, there's a diagnosis code. The situation I could see, whereas this happened the first time, then the next time the doctor was available, the pharmacist could call, verify that it was that the person had the diagnosis of sickle cell. That could be marked in that patient's chart, so that pharmacist would have that documentation from then on. There are also what we call hard overrides, which in this case would be a hard override if the plan says you have to call the doctor's got to justify the override before we can bill it and go through. There are also soft overrides where the plan notifies the pharmacy, watch this is an issue, it falls into this category, but we have ways that we can override that plan. So basically, what I was asking is that this become a soft override instead of the hard override that's required to get the physician involved, particularly when it's on a weekend, a night, patients in pain, and the physician's unavailable.
Thank you, Delegate. Any other questions from the committee? Okay. Is there anyone in the room that would like to speak in support of the bill? Anyone in the room that would like to speak in opposition to the bill?
He's getting closer, isn't he?
He's right behind you.
Madam Chairman, Doug Gray on behalf of the Virginia Association of Health Plans. I'm not in the for or against category, so I'm somewhere in between. I think administering this would be challenging, and I think there's a little bit of research that has to be done about what federal requirements apply to opioids and whether they can be waived by a state piece of legislation. I think we're uncertain about how we would administer this idea without creating unintended consequences. So happy to work with the gentleman, see if we can figure out, how it might possibly be done, but I don't think this is ready to go as a requirement at this point because we don't really understand how. And frankly, it would take some work to try to get there. One question I would ask is, has anybody else done this? I mean, if another state has done it, maybe we could follow their lead and, figure out how to administer it. But I don't have the answer at this point, so I was just raising the question, but I'm not for or against.
Thank you. Mr. Gray. Yes.
Yes, Madam Chair, members of the subcommittee, Karen Addison representing Pharmaceutical Care Management Association, which is the National Trade Association for the PBMs. Wanted to echo those comments and just make sure we're striking the right balance between making sure patients get the pain medication that they deserve, but also with an eye to patient safety, because opioids are highly addictive, as we all know. We want to make sure that we protect the patients from that aspect. So thank you. Thank you.
Thank you. Okay, do we have nobody online? Okay. All right, would you like to have the last word?
If I could, I had not received any opposition to this bill, but the two speakers that did speak did approach me as I was entering the room. Unfortunately, at that point in time, there really wasn't a mechanism of trying to work these things out. Regarding the comment about making sure that people aren't getting narcotics that don't need them, what my bill would do would not say that the pharmacist had to fill those prescriptions, but then they would use their good professional judgment. Thank you.
Thank you, Delegate Waxman. All right, this committee moves by motion. It's been properly moved and seconded.
Madam Chair, I have a substitute motion.
Delegate Sullivan.
Move to lay the bill on the table.
There's been a motion to lay the bill on the table. It's been properly seconded. Go ahead and open up the board and place your votes on the board. All right, this bill, HB 2106, has been tabled by a vote of 4-3. I want to thank Delegate Waxman for really tackling, I think, is a tough issue and having the appropriate discretions and trying to make sure that the proper safeguards and discretion are in place. I hope that we'll be able to get there, particularly for the examples that you're providing where people are in great pain.
Thank you. And if Mr. Gray will agree, I'll be glad to work with them on this over the summer.
I would encourage that, Mr. Gray and Delegate Waxman, if that would be good, we could do that. Yeah, we'll see what happens. Thank you very much.
Thank you.
2107 is the next bill with Delegate Waxman. If you would like to. Oh, you're funny.
Yes, Madam Chair, and there is a substitute that hope we can move.
Motion to adopt the substitute has been properly made and seconded. All in favor? All opposed?
Okay. Substitute motion basically takes out the piece about the commissioner that was changed in the bill and revert it back to what current law is of that piece. House Bill 2107 is brought back from this year. I think we did the same thing last year. It's a freedom of choice bill. This was an item that was brought to me by the Community Oncology Alliance. They are very concerned that their patients are often forced to get their chemotherapy products shipped to them through the mail. If it goes to the patient's house, it's called brown bagging. When it goes to the patient's physician, it's called white bagging. This is a kind of a freedom of choice issue. It's not saying that the patients have to get those products from the clinic or the physician, but that they have the opportunity, if they would like to request it, to get it locally. These drugs for the oncology group are very expensive. They have short half-lives. They're very toxic. When they show up at the clinics, it creates a problem. Where do they store them? What if the patient comes in, they do the blood testing to get their white counts to see if the white counts are in line and get treatment? They can be either too low or too high, and then the patient can't get the treatment. What do they do with these very expensive, very toxic products that they can't return, give to another patient? They are stuck, I'm assuming, with the cost of trying to have to dispose of these adequately. And that's what the bill does. It kind of gives the patient the freedom of choice, gives them the option to get it locally if they'd like to, and also recognizes the reimbursements for physicians in their clinics by these health plans.
Thank you, Delegate Waxman. Are there any questions from members of the committee at this time? Yes, Delegate Wilt.
Thank you, Madam Chair. So you said part of the issue is consumer choice.
Yes, sir.
Help me understand why they don't already have that.
Right now, some health plans require those patients, it's like a specialty pharmacy, that those medications are mailed from the health plan or the health plan pharmacy to the doctor's office of the patient, and the patient doesn't have the choice other than to pay out of pocket to get it locally, is my understanding. But we've got other people here that are experts in this field, too, that can speak to it.
Thank you, Delegate. Any other questions before we go to the room? Okay. Is there anyone in the room that would like to come forward and speak in support of the bill? Please go ahead and come down to the podium. Please remember to state your name and affiliation, and you have 1 minute. Please make sure to keep your comments to 1 minute. Thank you.
Good afternoon, Madam Chair and members of the subcommittee. My name is Shauna Clements. I'm the Chief Administrative Officer for Virginia Cancer Institute and an oncology nurse in the state of Virginia for the last 22 years. VCI is an independent community oncology practice that has served Virginians for the past 43 years, and we remain committed to ensuring that patients receive the highest quality treatment in a timely and safe manner. In recent years, insurers and pharmacy benefit manager mandated white and brown bagging policies have made it harder for patients to access the treatment they need when they need it most. These policies require that a patient's medications be delivered through an insurer PBM-designated specialty pharmacy rather than allowing providers to acquire and dispense these medications directly. It can lead to many issues for patients and providers, including improper delivery and storage of medication, increased patient cost, delays in patient care, and increased medical pharmaceutical waste. At Virginia Cancer Institute, we believe that oncologists working directly with their patients should be able to choose the safest and most reliable way to procure and administer medications needed for treatment. Thank you.
Thank you very much. Good afternoon.
Hello, thank you, Madam Chair and committee members. My name is Ricky Newton, and I'm representing Cancer Specialists at Tidewater Limited and all the patients that we serve, as well as the Virginia Association of Hematologists and Oncologists in support of HB 2107. I'm personally saddened that PBMs and insurers continue to get in between the patient-provider relationship by mandating that chemo drugs be filled by PBM-owned pharmacies and sent back to clinics for us to treat our patients when we already have these in stock and can treat day one. These cause delays and so much waste. My mother was being treated in our clinic for 17 months with metastatic breast cancer and stopped responding to her drug when we had to switch her to a new drug. In switching the drug, it took 38 days to get because the PBM didn't allow us to give the drug that we had the clinic on day one, and she had to wait 38 days. She wrote, "Still I wondered, did that 38-day span without medication shorten my life by allowing the cancer to spread quickly? Will I miss out on more holidays with family? Could I have a few more weekend trips with my husband? Unfortunately, there's no way of knowing if it would have made a difference or not. I do not know that this whole disorganized process fueled a situation that was already stressful and in several ways robbed me of the time that I'll never recapture." She passed 8 months later. Thank you.
Thank you. Thank you.
Hello, Chairman Maldonado, members of the committee. My name is James Lee. I represent the Community Oncology Alliance. We are the only national association that solely represents independent community oncology practices. We represent 70 community oncology clinics across the Commonwealth. You've heard from a couple of folks who we work with, and this issue is really about patient access, and as Delegate Waxman has mentioned, patient choice. Really, we're just here supporting a removal of a mandate on this type of policy for certain health plans, and we hope that you'll support this bill. Thank you.
Thank you.
Madam Chairwoman, thank you for the opportunity to speak. I'm Matt Jenkins, the Chief Pharmacy Officer of VCU Health, right here around the corner. We're just here to share that we support the Freedom of Choice Bill for our patients so that they can choose how they receive their care. Hospital pharmacies and clinics are enabled to provide the care when necessary due to the processes that my colleagues here have certainly shared due to the insurers' policies, and those have led to delays in care and increased risk for our patients. To put this in perspective, we've had pediatric patients requiring a complex therapy known as IVIG for clinic administration, and insurance is required to come from an outside pharmacy that we could not provide. That outside pharmacy attempted to deliver it over a weekend when the infusion center was closed, delaying therapy for a pediatric patient. Ultimately, the medication was not administered for this critical therapy. What I would ask you to consider as you weigh in on voting for today, whether or not to move this forward, is that if you don't support, is really how do you support patients having the choice to choose their care? We're allowing them to choose their care for healthcare, but we don't currently allow them to choose how to get that access. And truly, if it works so well today, then we have nothing to worry about in passing this. Thanks.
Thank you very much for your comments today.
Good afternoon, Madam Chair. Davis Gammon with the Virginia Hospital and Healthcare Association, and we support the bill.
Thank you. All right. We have somebody online?
Yes, ma'am. We don't know which one, though. One of the doctors is online.
Okay. We're in the room, opposition to the bill before we go online?
Madam Chair, I'm Doug Gray on behalf of the Virginia Association of Health Plans. I opposed this legislation last year and opposed it again this year. This legislation basically prohibits us from offering a discount and the most effective and cost-effective way to deliver meds. No one who spoke mentioned that they mark up the drugs by hundreds of %. And if they would agree to accept our specialty rate, then we wouldn't have these issues. But they don't want to. They want to mark it up. The whole point of this is to be efficient and effective, and that's what we do. Whether it's mail order, which is also wrapped into this bill, by the way, because it mentions delivery to someone's home. So, I mean, this really undermines the opportunity to create cost savings. That's why we oppose it.
Thank you.
Madam Chair, Karen Addison, representing PCMA again. We also want to echo the comment that this bill seems to wrap in home delivery for maintenance drugs by mail order. That is a concern because a lot of employers choose to offer their employees a discounted rate if they get their prescriptions through mail order. So we think that that would be a negative for the patients. So also oppose the bill. Thank you.
Thank you. All right, we're going to go online. I believe we have a couple folks online. Just one? All right. We can't quite tell who is online. We're going to ask you to, oh great, Dr. Cynthia Coffey. Thank you, welcome. Go ahead and introduce yourself and your affiliation, and please keep your testimony to 1 minute. Thank you so much and welcome. The floor is yours.
Hi, I'm Cindy Coffey. I'm a pharmacist with Riverside Health System. I am representing VSHP and VPHA, and I'm asking you to support House Bill 2107. Mail order pharmacies lack up-to-date information such as labs and the notes and complete medication lists, which help evaluate the appropriateness of therapy. Our health system pharmacy has access to the medical record, can screen for drug interactions and contraindications, and this helps with weight-based and lab-based dosing. White bag prescriptions are often associated with drug waste and due to changes in therapy or even to, misdelivered medications. And this, not to mention treatment delays, which may result in patient harm. To help prevent this undue harm to patients and additional stress, not only to these patients, but to help the healthcare team. These healthcare team providers are trying to move mountains to ensure our patients are cared for timely. It's the patient who ultimately suffers in this situation. Thank you.
Thank you. Thank you so much for providing your testimony today. I think that is all we have. Any final words you would like to share with the committee before we move to vote?
Yes, I could. Once again, this is a patient choice bill. It's not saying they can't use the mail order if that's the issue. The patient just has a choice to determine who their provider is. The comments that were in opposition actually, I think, make my point. Through these patient steering methods, that's the reason why the state has such a huge problem with pharmacy deserts that are expanding. The reason that pharmacies are now closing at a rate twice what they were a year ago. We've got some evidence to see that as well, too, that I'll be glad to present you. And as far as the markup, I think the FTC finally has got a first interim report and a second interim report you may want to look at that was just released a couple of days ago that talks about just how much the health industry side and the PBM sides really uploads, marks up these drugs that they're requiring to get done at their specialty pharmacies. Thank you.
Thank you. I guess your time is up. All righty. Any final questions from the committee? Okay. Well, this committee moves by motion.
This has to go to approves.
Mm-hmm. Yeah. Did I hear a second? I didn't hear a second. Okay. It's been properly moved and seconded. We do have a letter for it to go to appropriations. So go ahead and let's go. I'm sorry? Is there another question? Nope. Okay. Then let's go ahead and open the rolls. HB 2107 fails to report on a vote of 2-4. I want to thank the delegate once again for bringing this bill forward and encourage you to continue working on this important issue.
Thank you, Madam Chair and members of the committee.
Thank you. Okay, now we can move to Delegate Shin, who will present on Bill HB 2083.
Thank you, Madam Chair. There is a substitute that Council has prepared. If it would be the will of the committee to adopt said substitute.
Second.
Motion to adopt the substitute has been properly made and seconded. All in favor say aye. Aye. All opposed? Motion is adopted. You have the floor, Delegate Shin.
Thank you, Madam Chair. Madam Chair, The substitute actually shortens the bill even further and turns it into a Section 1 bill. And I'll start by first explaining the premise of the bill, then I can talk a little bit about why we ended up here in the substitute. So right now in the Commonwealth, in order for an uninsured individual to purchase health insurance via the health benefits exchange, there are two options. Option 1 is to sign up during open enrollment, which runs from November 1st to January 15th. And the second option is to sign up during a special enrollment period. And outside of open enrollment, a special enrollment period can happen when an individual experiences a qualifying life event. Getting married would be a qualifying life event, as would moving or changing jobs, and giving birth even. But pregnancy is not a qualifying life event, and so this bill is really just aiming to make pregnancy a special enrollment or qualifying event for special enrollment period. In 2022, the CDC found that 4 out of 5 maternal deaths were preventable, and some of those most at risk are low-income Black, Latino, Indigenous, people of color, 35 years or older, or carrying multiple fetuses. In 2021, 8.3% of Virginia women of childbearing age were uninsured, and in 2022, the state had a maternal mortality rate of 22.3 per 100,000 live births. There are states like New York who are already combating maternal mortality by having adopted a pregnancy special enrollment period just like this one, and which we, I think, as a Commonwealth and certainly as a legislative body, have really been working towards ensuring greater access to prenatal care and better outcomes of maternal care. While the population of women eligible for this new enrollment period might be small, we think that it is still critically important to make sure that they have coverage, as the potential benefits of here are so significant not only for the mother but also for the infant. In my conversations in developing this legislation and working with the Virginia Health Benefits Exchange, my colleagues there who have been so helpful, they actually told me that they have the authority already to establish a special enrollment period such as this. For example, after Hurricane Helene, they actually established a special enrollment period for folks who were impacted by Hurricane Helene. And so with that in mind, we pivoted to the Section 1 bill, which is not modifying existing statute, and it directs the HBE, which is the Health Benefits Exchange, to create a pregnancy period before January 1st, pregnancy special enrollment period before January 1st, 2026. And with that, I'm happy to answer questions, but I hope it will be the will of this committee to pass this bill.
Thank you, Delegate Shin. Are there any questions from members of the committee for Delegate Shin? Okay. Is there anyone in the room that would like to speak in support of the bill?
Madam Chair, Doug Gray, on behalf of the Virginia Association of Health Plans, we support the bill.
Thank you, Mr. Gray.
Good afternoon, Chair, members of the committee. Emily Hardy with the Virginia Poverty Law Center. We help run Enroll Virginia, which assists individuals throughout the Commonwealth access marketplace insurance, and we support the bill as well. Thank you.
Thank you. Is there anyone in the room that would like to speak in opposition to the bill?
Nobody online.
Okay.
Move to report. Second.
All right. Thank you. The motion to move to report with substitute has been properly made and seconded. Let's actually get our votes on the board. All right, it's been it has passed, reported with substitute 6-0. Thank you, Delegate Shin.
Thank you, Madam Chair and members.
All right, we are at the last bill, and I'm going to shift this over to Sullivan, to Rep. Sullivan, Delegate Sullivan, to be acting chair as I present my bill. 2099.
2099.
Yes,
thank
sir.
you, Madam Chair. You're going to present from there?
Yes, sir.
All right, Delegate, you have the floor. Go ahead.
Thank you very much. Mr. Chair, members of the committee, today I'm bringing before you HB 20. I have a substitute.
Is there a second? Second. All in favor of accepting the substitute, say aye. Any opposed? The substitute's before us. Go ahead.
Thank you, Mr. Chair. This bill, HB 2099, is the same as substituted, is the same as Senate Bill 1215 that passed the Senate yesterday. This bill is about prior authorization requirements. They're increasing in Virginia and nationwide, leading to delays in patient care and treatment and excessive administrative costs and burdens for healthcare providers. Providers and patients report struggling to find updated and clear information about prior authorization requirements and often suffer in pain and other ailments at the delay of response. Having administrative burdens on physicians take up valuable time that providers could be spending directly with patients, and requests are multiple step processes which lead oftentimes to back and forth with payers. Delays in prior authorization can also be detrimental to patient care. We have seen some of that. The burdensome and lengthy administrative process can lead to delays in necessary patient care and treatment. In some cases, it can lead to patients abandoning a care plan entirely, all of which have negative impacts on patients' health outcomes. So in this instance, just to state it very briefly, for prior authorizations that are urgent in nature, we are setting timelines of 72 hours for expedited health services prior authorization requests, and within 7 calendar days for standard requests for prior authorizations. No carrier can retroactively change or deny prior authorization unless the authorization was obtained fraudulently, the drug or service is removed from the market, or new safety issues arise. There are a couple of exceptions. The provisions do not apply to Medicaid, Medicare, TRICARE, or similar coverage plans, and carriers must notify providers of any changes to prior authorization requirements at least 30 days in advance. And finally, it's not applicable to HMOs, and let me grab the most recent changes that we did in the substitute that just makes it clear that no provision of this section is going to apply to HMOs that contract with multi-specialty groups of physicians who are employed by and are shareholders of that multi-specialty group, and where they also contract with HMOs in the community, and provide or arrange for the provision of the physician services by this physician members of the multi-specialty group, or by a contracted healthcare provider. So we're hoping that we can give some relief. If anybody has ever tried to secure a prior authorization, have waited and have suffered because of the delay, we're hoping that this will address that. We work really hard across the sort of sectors and stakeholders, and we think we're in a good place. Again, this is the cognate to Senate Bill 1215, which passed yesterday in the Senate. Thank you. I'm happy to take questions.
Thank you, Madam Chair. Any questions for Delegate Maldonado from members of the panel? Delegate Wilt.
Thank you, Mr. Chairman. I would ask, is there any fear that this may rush a decision which potentially could cause the wrong decision? So, here we say the safest vote's no. You can always defend that. You see that moving into this whole arena, and just so you get the pre-authorization. No, we're not going to do it. Oh, just a question.
Yes. Mr. Chair, I would say to the delegate that looking at the data, a lot of the prior authorizations, the delays aren't because the cases are complex necessarily. It has to do with the ability to not have consistent guidelines around response and balancing that with physician load and patient load. So I think that what we're seeing is the way this is set out, there will be a very consistent process that will help streamline and cut through that challenge of balancing patient load with the attention of the physician and administrative responsibilities. We haven't seen anything that says putting parameters around them will create misdiagnoses or improper denials. What we want to make sure is that people who are suffering, people who are in need of urgent responses to prior authorizations in particular, for the 3-day turnaround time or the 72-hour turnaround time, have that. There have been instances where people have been waiting several weeks to months for prior authorizations. And there is no case that is that complex that you should have to wait for months. Thank you, Mr. Chair. I
Thank
the
you, Delegate. Any further questions of the delegate from members of the panel? Delegate Wilk, you're done? All right. Members of the audience here, let's go support first. And there's Mr. Gray standing right there at the
Mr.
podium.
Chairman and members of the committee, I'm Doug Gray on behalf of the Virginia Association of Health Plans. This is a Peace in the Valley bill. The Hospital Association and the Health Plan Association have worked together to come up with this bill. And it's the first step in trying to promote a federal policy to have electronic prior authorizations for procedures. Electronic prior authorizations for pharmacy has already been completed and will go into effect in June. And it is required of all providers and all plans. This is the next step, and it will actually move towards beginning to go live in 2027. So we are a little bit early, and that's why you can see the language has a delayed effective date, because we still do not have final rules at the federal level. The federal application is to Medicare and Medicaid. We here are fully insured policies that we regulate. What we would like, both of us, and both organizations, is to have everyone have the same system and everyone use it. So we will be back with some updates next year, and eventually we will be back with a requirement that all providers use it and that all payers use it, so that we have consistency across the board. So this is our opportunity to move into the great new electronic future, which everyone else has already done except for healthcare.
Sounds like a terrific plan. We look forward to seeing you.
And we want to thank the patron. I want to thank the Hospital Association for working with us. We look forward to working together to make the process work better for everyone.
Thank you, Mr. Chairman, and I'd like to thank the Madam Chairman for carrying the legislation and championing this issue. My name is Davis Gammon. I'm speaking on behalf of the Virginia Hospital and Healthcare Association. We do support the bill and would like to not only thank the patron, but thank the Virginia Association of Health Plans and its members for working with us through this process. It really does bring clarity to, I think, a really complicated process. I think it's beneficial for, obviously, the patient. It's beneficial for the provider, but I think it's also beneficial for health plans to know what rules that we're asking them to play by in this kind of scenario. So I think it's really important for patients and providers, and really allows our providers to focus on delivering really important care to their patients. And as Mr. Gray mentioned, this is just one step in the process, I think, of making prior authorization work better. It's an important tool used, to Delegate Wilt's point, to help ensure that care is being delivered appropriately. So again, we thank the patron, and we ask that the subcommittee move it on to the full committee.
Thank you, sir. Is there anyone who wants to testify against this bill? Okay. Is there anyone on the line?
No, sir.
All right. Delegate Maldonado, do you want the last brief word with this bill that's on a freight train?
Other than to say thank you for the consideration. I thank not only the stakeholders and the partners in helping us get to a good place here, I also thank the committee, Mr. Chair, for your consideration today.
Yeah. Is there a motion?
I'd move to report with substitute, Mr. Chair.
Motion to report the substitute, properly second. Clerk will please open the roll. Clerk will please close the roll. Substitute reports, I think that was 6-0. Delegate Maldonado, 2100.
Thank you.
Oh, we did pass that by? Yes. All right, good.
Yes.
Then
we
we
are
are
complete.
Done. I pass it back to you.
Yes.
Want to adjourn us?
Thank you. Thank you, Delegate Sullivan. I'd like to thank everybody today for your time and thoughtful contributions. We are adjourned.
More work to come.
Yes.
Good job, Madam Chair.